Hello, Brad Elmer. I'm going to go over cardiac meds real quick with you guys. First thing I'm going to do is I'm going to go over diuretics. So I'm going to try to explain some of the pathophys as I go along with things here so you can hopefully understand it a little better. So initially how things work with your body is your blood pressure and heart rate are inversely related. So when your blood pressure gets low, your heart rate's going to increase. By your blood pressure getting low, your heart rate has to increase to basically balance out your cardiac output. Cardiac output is the amount of blood that your heart is pumping through your peripheral vasculature. So when your pressure is low, your heart has to beat more to get that cardiac output back up. Now, generally speaking, if blood pressure is low for too long due to bleeding or something like that, you're going to see tachycardia, so your heart's going to jump up with the hypotension, but eventually your heart can't keep up because it's going to lose all that blood volume. Then you're going to see a late sign of bleeding is actually going to be bradycardia because your heart just loses all the blood and it goes down. So that's kind of like a random important fact. The other thing with blood pressure is it's directly related with your blood volume. So when your blood volume is high, you'll have a high blood pressure, you'll have hypertension. When your blood volume is low, you will have hypotension. So generally, when someone has low blood pressure, what you're going to do is you're going to give them a fluid bolus, give them a bunch of saline, kind of increase their blood volume. That should raise their blood pressure. And like with that, if your blood pressure is high, something you can do is you can give cardiac medication to help lower it down mechanically, or if you can tell they have a lot of fluid in their body, you can give a diuretic. So diuretic basically is going to help to draw some of that fluid out of the bloodstream, out of the vasculature, and just have you pee it out, thus lowering your blood pressure. So I'm just going to go through my notes here, just kind of bear with me. So all diuretics work in your kidneys. I have a little board over here. I kind of do a little something. I'll show it in a little bit. We'll go over everything, kind of describe that. So the important thing to know with diuretic is they have to have kidney function. If they are in acute kidney failure or end-stage renal failure, it won't have any effect. In acute kidney failure, renal failure, you can have some effect, but the problem is you can end up taxing your kidneys so much you actually cause them to go in worsening kidney failure. So the big thing to be aware of would be your BUN and creatinine levels. BUN should be roughly 10 to 20. If you're above 20, you're in early renal failure, and then so on and so forth. The other thing to be aware of is creatinine levels. A general rule of thumb would be 0.5 to 1.2. Both of those are markers of your kidney function, so kind of be aware of those with giving a diuretic. So if you see a lab value on a test and it's a BUN that's like 25, you're not going to want to give the diuretic. You're going to want to call the doctor to clarify your order or something like that. The other thing, the first one I'm going to go over is your thiazide diuretics. This is usually hydrochlorothiazide. This is generally used for what's considered essential hypertension when they don't know what the cause of hypertension is. It's something's wrong with the body, you're hypertensive. So you're going to give them a moderate diuretic to kind of pull some of that fluid off, decrease their blood volume, lower down your blood pressure. Before I go on, I should probably go over blood pressure. So blood pressure, generally speaking, is going to be 120 over 80. Anything over 140 over 90 is going to be high. Anything over 90 over 60 is going to be low. So just kind of throwing it out there. Basically, the things to be aware of with diuretics, they're all pretty much the same. Is one, monitor urine output. Make sure you're actually having increased urine from the medication you've given. Two, you need to be aware of is you're flushing out the water from other kidneys, is you're going to flush out electrolytes. You're going to flush out sodium, and you're going to flush out potassium. So your sodium levels should be 135 to 145, potassium 3.5 to 5.1, sometimes it's 5.2. Kind of just verify with ATI or your lecture notes what it should be. But That being said, you can have hyponatremia and hypokalemia, but you're going to have signs of hypokalemia before hyponatremia. But you still need to be aware of both those levels. You're going to end up having hypokalemia first, just because your potassium in your extracellular fluid is so low that it's going to be flushed out quicker. That's what you kind of have to be aware of. And your signs of hypokalemia are generally going to be nausea, vomiting, diarrhea, and muscle pains. And then ECG changes, but they're going to be slower changes. I have it on my board. I'm going to show you later. It's going to kind of describe that a little better. And so you also need to be aware of, with your diuretics, any other medications that can affect your potassium levels, such as digoxin, ACE inhibitors, ARBs, and then lithium. Lithium is a bipolar medication you won't cover until later on, but I'm kind of putting it out there now so it's in the back of your head. The other thing to be aware of with hydrochlorothiazide is photosensitivity, general side effects. It's going to be where they put on sunscreen when they go outside. Some random thing that may come up. The other one, next one, is going to be your loop diuretics. This is going to be your Lasix, furosemide. This one is, your loop diuretics are more potent. They're stronger diuretics. They theoretically, little asterisk in the air here, are not used for hypertension. These are going to be used for fluid overload or like CHF. They got the crackles on the lungs, they have the JVD, they're fluid overloaded, they have edema. So they have a large amount of fluid you need to get off. You're going to use Lasix. Now, that being said, you will give Lasix to people who are hypertensive because odds are, if they are fluid overloaded, again, they're going to have a higher blood pressure, that blood volume. So you're not giving it for the hypertension, you're giving it for the blood volume that's causing the hypertension. Just a little caveat there. So again, the same thing to be aware of with your Lasix is going to be your hypokalemia, hyponatremia. But then also you need to be aware of ototoxicity, which is ringing in the ears. So you have to give it slowly, or you can cause them to go deaf. So generally speaking, the fastest you can give Lasix is 10 milligrams over a minute. So generally what happens is you're probably going to give 40 or 80 of Lasix, and so you're kind of sitting there awkwardly making small talk with the patient for 8 minutes because you got to slowly push the medication in so they don't cause them to go deaf. And again, with Lasix, you need to be aware of drug interactions with digoxin, ACE inhibitors, ARBs, lithium, stuff like that. Alright. Next is potassium-sparing diuretics. So potassium-sparing diuretics, they're only diuretics in class because they are affected on your kidneys. They don't really have a true diuretic effect. They don't cause you to lose a large amount of fluid. What they do is they work on the end of the kidney tubule right for the collecting duct, and it causes this, counteracts other diuretics and sucks up more of the potassium. So your other diuretics are just causing your body to lose the potassium because that water is just flushing it out. And so you're just losing the potassium. So spironolactone, a potassium-sparing diuretic, is going to cause a reuptake of the potassium. But the thing to be aware of in your cells is, remember, intracellularly you have high potassium, low sodium, extracellular, high sodium, low potassium. So potassium and sodium are inversely related. So when you absorb one, you lose the other. So with spironolactone, you're going to see signs of hyperkalemia and hyponatremia because you're going to lose more sodium. And that little bit of sodium you lose is with sodium and water always go together. So that's where it's kind of a diuretic. So you're losing that sodium, so water is going to follow the sodium. The other thing to be aware of with this one also is going to be your ACE inhibitors and your ARBs, more so than your other medications, because ACE inhibitors and ARBs cause hyperkalemia. I probably shouldn't have said it for the other ones. It's actually these. I misspoke earlier. Sorry about that. So your ACE inhibitors and ARBs are your drug interactions for your potassium-sparing diuretics because they cause you to maintain more potassium. So you're going to have a higher chance of hyperkalemia. In hyperkalemia, you can still have your nausea, vomiting, but you have like muscle cramps from overexcitability from the potassium. And you're also going to see EKG changes, but you're going to see more something called a peak to T wave. What you also need to be aware of with these is any sort of sodium or salt substitutes, because if they are on Lasix or cardiac meds, they're probably going to be on a cardiac diet, so they can't have too much sodium. And so they're going to want a little flavor for their food. Mrs. Dash is probably what's probably going to be used, which uses potassium chloride instead of sodium chloride as a salt substitute. So you're basically giving them a large amount of potassium instead of sodium. So you have a lot higher chance of them going into hyperkalemia with a salt substitute with the spironolactone. Hopefully that makes sense. I'm going to pause the video for a second. Well, I was going to show you the board I had written up, but I realized with cameras, angles are switched, so it looks like it's completely backwards. So I'll take a picture of it and then post it after this video with a little explanation. I basically had a kidney tubule, showed the medulla, the cortex of the kidney, kind of showed the water-rich, sodium-rich, and how diuretics work, and the EKG changes with hypo and hyperkalemia. But I can't show you because it's backwards. So otherwise, I'll go on to osmotic diuretics. So osmotic diuretics, mannitol, is not going to be for fluid overload. It's not going to be for hypertension. It's going to be for increased ICP, intracranial pressure. So basically what that means is going to be a lot of fluid, cerebral edema, some swelling post-stroke, head trauma, something. And so you're going to notice that in ICP monitor, the pressure is getting higher. And so when the pressure gets higher, the brain tissue gets compressed, thus you have neurological changes. So what you want to do is you want to pull some of the CSF, the fluid, off of the brain to decrease that pressure. So you can give mannitol. So the mannitol basically what's going to do is just pull the fluid from your brain tissue, your cerebral tissue, into your body. So this could actually end up causing circulatory overload. It could cause you to have increased blood volume because you're pulling all that fluid from your brain into your bloodstream. Now, theoretically, the mannitol should also cause you to have an increased urine output, but that might not always be the case. So once you give the mannitol, you have to be aware of crackles in the lungs, DVT, increased blood pressure, edema. You're probably going to want to give another diuretic, either hydrochlorothiazide or Lasix, and pull some of that extra fluid off. So also be aware of it. With this, you can see an increase in the blood pressure and thus a decrease in the heart rate. So kind of be aware of that. Alright, hopefully that all makes sense. Just a second. Okay, now we're going to go over the rest of the truly cardiac medications. And with these, they do tie in with your kidneys and your blood volume. So I kind of explained blood volume and how that works with your heart rate and your blood pressure earlier. Is when your blood pressure gets low, your kidneys, what's called your MAP, your mean arterial pressure, decreases, which means your kidneys aren't getting as much blood as they want because they filter your blood with all the toxins and all that in the fluid. So your kidneys go, hey, give me some more blood, and so they release something called renin. What the renin does is the renin causes the production of angiotensin. Angiotensin constricts the blood vessels, and when you have vasoconstriction, you have less surface area for your blood to go through, which means things are like, it's a tighter circle, like the Play-Doh, you squeeze it through a little hole, it presses out quicker. So you're constricting the blood vessels so that the blood has less area to kind of expand, so there's higher pressure in those vessels. So vasoconstriction, higher blood pressures, vasodilation, lower blood pressure. So basically, kidneys don't get enough blood, they increase renin, increases aldosterone. Aldosterone causes vasoconstriction, which is then going to help increase your blood pressure to get your kidneys more blood, but angiotensin also is going to stimulate the release of aldosterone. And aldosterone is going to cause you to retain sodium, which then causes you to retain water. So that's also going to increase your blood volume, thus increasing your blood pressure. Also in there, I forgot to mention, the angiotensin goes from angiotensin 1 to angiotensin 2. It gets converted with an enzyme. So that's kind of important with your heart rate medication. This is called the RAA system, which is kind of basically what your kidneys do to help control your blood pressure. The other thing to be aware of in your body is there's various receptors. There's alpha receptors and beta receptors. So alpha receptors basically are going to lead to vasoconstriction, thus increasing your blood pressure. There's beta receptors, there's beta 1 and beta 2. Beta 1 is going to stimulate your heart rate. So increasing your heart rate, you can increase your blood pressure by causing your heart to beat faster. You increase that blood flow through your bloodstream, through the vasculature, causing an increase in blood pressure. It's also going to, beta 1 also cause your kidneys to secrete the renin, which then causes that RA system to cascade, leading in increased heart rate, blood pressure, increased blood volume. But then there's also beta 2. Beta 2 leads to vasodilation and bronchodilation, and then also glycogenolysis in your liver, which basically means the breakdown of glycogen in your liver to glucose. So it's going to affect your blood sugar levels. It's going to technically lead to some minor vasodilation. So it's going to have a decrease in your blood pressure, but it's also going to cause bronchodilation. Beta 2s are predominantly used for pulmonary problems, people with asthma and COPD, to open up the bronchioles, increase the airway so they can get more air in. So we're going to get back to that in a little bit. But first we're going to talk about things kind of out of order, but that's how my notes are. Things that raise your blood pressure. These are called vasopressors. There's also something called inotropes, which I think inotropes are in the farm notes. As far as I'm aware, they're not actually covered in class, so I'm going to kind of ignore them. But I will say inotropes, they don't raise your blood pressure, but they raise your cardiac output. So it's a little different. So if you see it somewhere else, I can go over it more later on if you want. But right now I'm just going to talk about vasopressors. Vasopressors basically cause systemic vasoconstriction throughout your body, thus raising your blood pressure. So you're going to constrict your blood vessels, causing your blood pressure to go up. So the first one is epinephrine. So epinephrine, quite frankly, is going to affect your alpha receptors, which I said it's an alpha 1 agonist. So it's going to stimulate your alpha 1s, which cause vasoconstriction throughout your body. So it's going to end up in the huge decrease in your blood pressure. So the things to be aware with vasopressors is usually they're kind of a last resort. You're ready to give your fluid bolus. That didn't work. The blood pressure is still low. It's still less than 90 systolically, less than 60 diastolically, or your MAP is less than 65. A MAP of 65 is generally the rule of thumb to have maximum blood perfusion to your kidneys and to your brain. So MAP 65 is usually kind of the key when you're going off blood pressure. It's not so much as systolic and diastolic as the MAP. What is your average pressure? Are your organs getting enough blood? So the problem with vasopressors is you have to give them to a central line. So you have to give them to some sort of access right into your heart. Because you give it in a peripheral IV, it causes vasoconstriction. So it's just going to collapse that vein right away, leak into the peripheral tissues, thus leading to more vasoconstriction, leading into necrosis. So basically it's going to clamp up all those blood vessels in the surrounding area, killing off the area. That being said, long-term use of vasopressors will have the same thing. You're going to cause vasoconstriction, and when you're doing vasoconstriction, predominantly you're going to constrict your peripheral vasculature more than your core. So your fingers, your toes, arms, and legs, it's going to be constricted more so the blood stays more in your core and in your brain. So long-term use will end up seeing necrosis and just cellular death in your peripheral limbs, your hands, feet, toes, all that. The other thing to be aware of with epinephrine is it's causing stress in your heart. You're causing it to artificially raise your blood pressure, which then can lead to increased demand in the heart and myocardial infarctions. So you're basically going to cause the person to have a heart attack, thus leading to more cardiac complications later on. The other medication that's covered, at least in my notes, is dopamine. Dopamine works in 3 different levels. At the first level, it's just going to be used kind of as prophylactic in someone who has acute renal failure post getting contrast dye in the CT. So it's just basically going to increase renal blood flow to the kidneys, kind of help prevent damage to your kidneys from some sort of toxic effect. That's at a low dose. At a moderate dose, you're going to start to see an increase in the heart rate, and you're going to see an increase in blood pressure. So dopamine, you give it for vasopressor because it's going to cause constriction and raise the blood pressure, but it's also going to raise your heart rate. So it can raise your heart rate to a point where you're going to stress your heart out, causing an MI and other cardiac complications. At a higher dose dopamine, it just basically causes extreme vasoconstriction, thus raising your blood pressure in that way. But the same thing, it's also going to raise your blood pressure. So vasopressors should only technically be used for short periods of time, so you don't run into those necrotic effects, and only given in central line, not given peripherally. Okay. Next is going to be antihypertensive medications. So first ones are ACE inhibitors. These are angiotensin converting enzyme inhibitor. So when I said earlier that RA system, that renin, angiotensin 1, angiotensin 2 to aldosterone, this is basically going to stop the angiotensin from getting from 1 to 2. So you're going to basically stop that cascade. So you're going to stop the vasoconstriction. You're going to stop the release of aldosterone to increase the blood pressure. So all your ACE inhibitors are kind of an easy way to identify because they all end in pril. So anything in PRIL is going to be an ACE inhibitor, so you automatically know what it is. Even if you've never seen the name before, if you can identify a prefix or a suffix of a medication to another class, you can classify it that way. So it's kind of a good way, just rule of thumb, know this. So what's going to happen with an ACE inhibitor? So you're going to, body's no longer going to release aldosterone in your body. So you're no longer going to save sodium in water. And when you save sodium in water, you lose potassium. So what's going to happen is you're going to lose sodium in water, thus decreasing your blood volume, decreasing your blood pressure, but you're also going to then retain more potassium. Earlier when I said you need to be aware of ACE inhibitors and ARBs with thiazides and loops, I misspoke, remember? It was only for your potassium sparing diuretics you need to be aware of. So basically you're going to cause an increase in your potassium because you're not going to be losing it from the aldosterone. So you have signs of hyperkalemia. The other thing to be aware with ACE inhibitors is you're just going to have a very dry ACE cough. There's no complications with the cough, it just annoys patients. And so they'll switch them from an ACE to an ARB. But before we get there, the other one side effect is angioedema. Angioedema is basically facial swelling of your lips, tongue, mouth, and airway. So angioedema may not seem, so their mouth's a little swollen, face is swollen, what's the big deal? What's going to happen is you're basically going to swell up enough that you're going to occlude their airway, and it's going to have a hard time risk for breathing. So anyone with angioedema generally goes to an ICU for monitoring for 24 hours to kind of make sure they're getting adequate oxygenation. The other thing to be aware of throughout all of these is you can have a higher chance of causing hypotension. Anything that causes hypotension, you're going to have a huge risk for orthostatic hypotension, which basically is when someone stands up, the blood pressure drops, they get dizzy, they fall down. Orthostatic hypertension happens because the blood pressure is so low, your heart rate kind of centrifugal force. You ever had seen someone with a bucket of water, they spin it around and the water stays in that bucket? It's kind of what's happening with your blood. So when you get up, you stand up really tall, all your blood just kind of rushes down the bottom of the bucket. Thus, the blood in your brain gets lowered, and so they lose consciousness, get dizzy, and they collapse. So safety is going to be a huge concern with all your antihypertensives, anything that lowers your blood pressure. Safety is important. The other drug interaction with ACE inhibitors besides your potassium-sparing diuretics is going to be lithium. I won't go into what lithium does. I'm just going to again put it out there so you can remember it for later. So say someone had the ACE cough, it annoyed them, but it was working to control their blood pressure. So you can switch them over to an angiotensin receptor blocker, or an ARB. These are all end in artin, losartan, so it's ARTAN. Again, that's your suffix to kind of attach onto, to be aware of, okay, if I see artin, every artin I come across is going to be an ARB. ARBs generally are the exact same medication as your ACE inhibitors, but instead of blocking angiotensin 1 to angiotensin 2, you're basically blocking angiotensin 2 from having an effect in your kidneys, but still you're causing the blockage of aldosterone from being released. You're going to lose the little bit of water, the sodium, and you're also going to retain the potassium. The only thing is you will not have the ACE cough attached to this, but you can still have a higher chance of angioedema. You need to be aware of your potassium-sparing diuretics, be aware of hyperkalemia, and again, be aware of any sort of lithium use. Alright. Next thing we're going to get into is calcium channel blockers. These are kind of in two different classes. There's ones that are used for hypertension and some that are used for antiarrhythmics. I'm going to get into the antihypertensive ones first. These ones all end in generally diapine or iapine. D-I-P-I-N-E. And what these do is, remember, your heart is a muscle. Muscles contract through the influx and outflux of calcium ions through the muscle tissue, and so you're blocking those calcium channels from allowing the calcium influx to come in and out. Thus, you're going to decrease the contractility of the heart. So basically what that means is you're causing your heart to beat less. Causing your heart to beat less, you're going to lower your heart rate and lower your blood pressure. Because if your heart's not beating as strongly or as much, your blood pressure is going to go down naturally. So the good thing about calcium channel blockers is it also decreases the demand of oxygen on your heart. So if someone's had angina or myocardial infarctions in the past, a calcium channel blocker is kind of nice to help decrease that oxygen demand. The other things to be aware of is one, safety, hypotension, but it can also lead to abdominal discomfort and peripheral edema. Predominantly, the abdominal discomfort is from constipation, and because your GI tract is also a muscle, so you're going to kind of slow that GI tract down, so you're going to have them be constipated, just things are going to back up. And the peripheral edema, honestly not entirely sure, but if I were to guess, it's probably just from that decreased contractility. The blood pressure is not allowing the blood to come all the way through the vasculature, so it's pulling your legs, causing edema. Alright. The other thing to be aware of is your heart works through electrical conduction. If you are doing something to affect electrical conduction in your heart, you're going to lead to potential complications, such as heart blocks. Heart blocks right now for your class, all you need to be aware of is a heart block is some sort of misconduction in the heart. Things aren't going as smoothly as they should. By the calcium channel being blocked, you're stopping that electrical conduction going through the heart, thus leading to heart blocks. This can then lead to like VFib, VTAC, bursting coating. So next thing is going to be your beta blockers. So again, I already covered what beta 1 and beta 2 do, but predominantly speaking, beta 1 will affect your heart, beta 2 will affect your heart and your lungs. So there's selective beta blockers and non-selective beta blockers. Selective beta blockers just affect your heart. Non-selective beta blockers affect your heart and your lungs. So if you're going to block beta 1, what you're going to lead to is going to lead to vasodilation, which is going to help you lower your blood pressure, increase the blood flow to your heart. Because the other thing to be aware of is when you're dilating your vessels, you're dilating vessels of your heart, your coronary arteries, which then allows you to get more blood flow to your heart. So a common thing with people who have MIs is you put them on a beta blocker, because that's dilating their coronary arteries, getting more blood to the heart and get through those blockages, decreasing the chance of having angina in the future. The problem is going to be with your non-selective beta blockers, which is propranolol. So with your non-selective beta blockers, remember your beta blockers, your beta 2 led to bronchodilation. So you're going to block that. So you're going to actually lead to bronchoconstriction. So people who have asthma and COPD, this is going to be a problem, basically because you're going to cause them to have an asthma attack and have COPD exacerbations. Otherwise, with your beta blockers, what you need to be aware of is bradycardia, because you're slowing down the heart. Also, you're slowing down the heart rate and you're causing vasodilation. So decreased cardiac output, bradycardia, and hypotension. Again, you're slowing things down, so you're going to potentially see some form of misfiring electrical conduction. You're going to see heart blocks. The other thing to be aware of with your beta 2s is, remember, your beta 2s affected the breakdown of glycogen in your liver, basically making the increase of glucose in your bloodstream. As you're going to see effects with diabetes, that blood sugar levels are going to be not as controlled as well. So generally speaking, you don't want to use a beta 2, you don't want to use propranolol, you want to use metoprolol. There's also an alpha 1 and beta blocker, which is Coreg or Carvedilol. This one's commonly used because it's a non-selective beta blocker, but also affects your alpha 1, so you can give a smaller dose because you're affecting multiple receptors. By affecting multiple receptors, you give a smaller dose, so you're going to lead to decreased cardiac output, you're going to lead to vasodilation, and you're going to cause a decrease in the heart rate and blood pressure at a smaller dose. But again, same problems do kind of apply. You have bradycardia, hypotension, and hyperglycemia from all the effects with the breakdown of glycogen. Sorry. Quick view of my notes here. I think that's pretty much it. If I do miss things, feel free to let me know in the comments, and I can kind of reevaluate things. But going on, say someone's in a hypertensive crisis, they're having chest pain, they're having angina, what do you generally give? You're going to give them some sort of nitro derivative. Nitroprusside is usually the one that's used. Nitroglycerin is only going to be the pill form. Nitroprusside is the hung IV medication. So nitroprusside, nitros basically cause extreme vasodilation. So you're going to dilate the arteries and your veins. They dilate everything out. So it's going to cause a huge drop in your blood pressure quickly. Nitros generally can lead to headaches, drowsiness, cardiac conduction abnormalities, heart blocks. It can also lead to cyanide poisoning, because the breakdown of nitroglycerin is cyanide. So you have to be aware of their cyanide levels in your body and how much nitro you're giving. But you can also give thiosulfate. Thiosulfate is your antidote to cyanide poison, so it's going to kind of prevent that from happening. The other thing to be aware of is you can see very, very marked hypotension, that's called. Basically, it's going to be a huge decrease in blood pressure very quickly from dilation. So it has to be, start doing infusion slow and titrate up slowly. Otherwise, that's pretty much that. And then I'm going to go into what you're going to do with someone who actually has a heart attack. So if someone has angina pectoris, which is basically chest pain, you're going to want to give them nitro. But with giving them nitro for chest pain, or nitroprusside for that matter, especially in your more mature male populations, I'll say, you need to be aware, you need to ask them if they're on any erectile dysfunction medications. Erectile dysfunction medications are actually nitro derivatives. They were initially designed to control blood pressure, but they cause vasodilation in a certain area of the body that's more marketable than blood pressure medications. So basically what that means is if they are on an ED medication, they're already on a nitro, so they're already having some sort of blood pressure control, and you give them a nitroglycerin tablet, you will cause their body to completely drop out their blood pressure. They will pretty much code instantly, which is not a good thing. So you want to be aware. Again, ask them if that happens. It'll kind of help prevent the fact that the elderly patient's going to die. Anyways, nitroglycerin, again, so what's happening with the angina pectoris, the heart attack, is the coronary arteries around your heart are not getting enough oxygen, and so they're dying off, causing pain. The nitro is going to cause extreme dilation of those coronary arteries to kind of help open them up to hopefully allow some of that blood to get through. You're going to, again, use the acronym, the MONA protocol, but you don't actually give it in that order. You're going to give it oxygen, aspirin, nitro, and then morphine. Because what is the actual problem that's being caused? The problem that's being caused is your heart's not getting enough oxygen. So how do you fix that? Increase the oxygen they're getting. Secondly, give them a quick aspirin chewable. Aspirin is an antiplatelet aggregator. So you're going to hopefully kind of prevent things from getting worse and hopefully kind of open up those arteries a little bit. Then you give them the nitro. The nitro is the big thing. It's going to hopefully vasodilate and open up those blood vessels, get the blood through to the heart tissue, fix the problem. If that doesn't work, you can also give morphine. If they're still having chest pain, you give morphine. Morphine is not only going to decrease the pain they're having, but it's also a CNS depressant, so it's going to depress your CNS, depress your body systems, thus decreasing the demands on your heart, and your heart's going to hopefully slow down with that. Quick note on angina: there's several different types. There's stable, unstable, and variant. I'll just kind of go through these very quickly for you guys. Stable angina is when someone is, say they're out shoveling snow in the winter, they've been shoveling for a while and they have the chest pain, they stop, it goes away. It's stable. When they do some sort of exercise, the heart pain comes, goes away with rest. Unstable angina is when grandpa's sitting drinking a Pabst on the recliner watching TV doing absolutely nothing, and then next thing you know he's grabbing his chest and he's on the ground. It just happened suddenly. There's nothing else to know what's going to happen. Variant angina is usually spontaneous, very quick, it comes and goes. It's predominantly in menopausal women due to the hormonal changes they're going through. It happens when they're asleep. It's very treatable. Not treatable, but it's not as serious as the others. One thing I forgot to mention with your nitros is when you stop the nitro drip, you are going to have a higher chance of reflex tachycardia. So this also works for any antihypertensive. So if you're on an antihypertensive medication and you stop it, your body's going to rebound probably back beyond where it was because you're chemically maintaining their hemodynamics, your homeostasis. You kind of threw it in flux. When you take it away, your body doesn't know what to do anymore, so it can't control itself. So it's going to shoot up to become tachycardic, hypertensive, so on and so forth. And I missed the important thing with nitro, and that is you give it 3 times, 5 minutes apart. So you get the nitro tablet under the tongue, the spray, something. They have to feel that tingle. If they don't feel the tingle, the nitro is expired. Nitro expires fairly quickly, and so grandma and grandpa probably had the nitro pill sitting around for the last 5 years. To take it, it's not going to have any effect. It's expired. So you have to make sure that it actually is not expired and has an effect. So you give it 3 times, 5 minutes apart. Yeah, that's pretty much that. Alright, moving on. So, next one I'm going to go over is a cardiac glycoside. There's only one. It's digoxin or lanoxin. It's just probably going to be called digoxin. Basically what this does, it is going to cause an increase in the contractility of the heart, but it's going to slow down the heart rate. So what that means is your heart's going to beat stronger but slower. So it's going to be for some sort of, if they're in heart failure or if they have AFib or aflutter, some sort of atrial dysrhythmia, you want to slow the heart down, but then also increase the strength of the heartbeat. So you're going to get hopefully more cardiac output from one beat than we would get off of 3 lesser strong beats. So the digoxin, again, harder beat, stronger beat, less beats per minute, so decreased heart rate. So the thing to be aware of with the digoxin is it can lead to toxicity. It's a very easy therapeutic range to be aware of, 0.5 to 2. Anything over 2, you're going to have a higher chance of digoxin toxicity. Digoxin toxicity or digitalis can be reversed with Digibind. Digibind basically is the antidote for digoxin. The main thing you're probably going to see is it's going to be blurred vision or yellow halos around the peripheral. It's going to be the first sign you're going to see when someone is in digoxin toxicity. I was going to see decreased heart rate, anorexia, and nausea, vomiting. But the main thing is going to be those yellow halos around your eyes. The other thing to be aware of with digoxin, as I kind of point out with your diuretics, all of them, and your ACE inhibitors in your ARBs, is going to be your potassium levels. So when your potassium levels are low, when you have hypokalemia, your digoxin effects are going to be higher. So your digoxin is going to work stronger. It's going to have decreased, higher chance of bradycardia. So, and then, which is going to be caused from your diuretics, your loops, thiazides. But then you're also going to be aware of hyperkalemia is going to have less effects of digoxin, which is going to decrease the effects of digoxin, which is going to be your ACE inhibitors and your ARBs. So when you're having hypokalemia and you have increased effects of digoxin, that's when you have the risk of digoxin toxicity. So you guys can be aware of your potassium levels and how they relate to your digoxin. Also, calcium channel blockers can decrease the clearance of digoxin, thus leading to, again, higher chance of toxicity. Any sort of renal impairment will also affect your digoxin secretion, thus causing digoxin toxicity. Next, real quickly, we're going to talk about the drugs that are used for dysrhythmias. So the first one is going to be lidocaine. This is what, if you've ever gone to the dentist and had a cavity, this is what they give you for a numbing agent. But if you give it IV in a larger dose, it can actually cause systemic effects. So lidocaine is going to be for severe ventricular dysrhythmias. You don't need to know what those are, but they're VFib and VTAC. Just be aware, lidocaine, ventricular arrhythmias, and then also what you're going to see with lidocaine, you can see CNS depression, drowsiness, altered mental status, increased chance of seizures, tremors, and you're also going to see respiratory arrest. So when you give someone lidocaine, it's usually in a cold situation, you're going to want to be aware of their breathing during, after you've given it. You can make them go from a cardiac arrest to a respiratory arrest. Something you kind of need to be aware of. The next one is amiodarone. Amiodarone is going to be for atrial and ventricular dysrhythmias. Your atrial dysrhythmias are going to be your AFib, atrial fibrillation, and atrial flutter. I'll go over those real quick because they're kind of easy to explain. In atrial flutter, what is happening is the SA node is what usually starts off your heartbeat. That sits in your atrium. So there's a misconduction in your SA node. If it's in atrial flutter, what's happening is your SA node's firing very rapidly. It has very clear distinction like P waves on your EKG. So you can see kind of like a little sawtooth firing of your atrium and very occasional rhythmic ventricular contraction. That's your heartbeat. It's going to be regular. And then in atrial fibrillation, what's happening is your atria isn't really beating. It's just kind of quivering randomly, and then sporadically the conduction gets through to the rest of your ventricles, causing a beat. So atrial fibrillation is usually very fast conduction, but it's also very irregular. So what amiodarone is going to do is it basically slows down, causes your heart to kind of slow down to allow itself, the SA node, to kind of relax and then re-get itself back in sync. But with the same thing, you gotta be aware of, if you're affecting the electrical conduction, you can cause the reverse problem of bradycardia and then heart blocks again. The next one is going to be those calcium channel blockers that I didn't cover before, but I'm covering them now. So it's diltiazem / cardizem or verapamil. These are the other calcium channel blockers that are just for hypertension, and then diapine, cardizem, and verapamil. There's no real clue to remember them, it's just what they are, but they are calcium channel blockers. So they are going to stop the calcium channel ions from causing an influx, decreasing your contractility of your heart. And this is how it's going to help control atrial arrhythmias. So I kind of went through them. So it's that atrial arrhythmias is basically the SA nodes firing too quickly. So if you slow it down, hopefully the heart will kind of go, oh, that's right, I'm not supposed to be going this fast, I'm supposed to be going a little slower, thus being controlled better. The other thing to be aware of is atropine. Atropine, which hopefully was already covered in class. This is going to be used for symptomatic bradycardia. Atropine is an anticholinergic medication, which means it's going to cause a stress response. So it's going to cause your body to kick in that stress response. It's going to cause you to have an increased heart rate and increased blood pressure. So when someone is having symptomatic bradycardia, they're having really low, wide complexes, you're going to give atropine to kind of help increase that heart rate. The other thing to be aware of is it's very strongly anticholinergic, so it's going to be very strongly anti-sludge. So what that means is you're going to have an increased chance of constipation, decreased urine output. But then also atropine can be used in cases of extreme diarrhea. It's basically going to, remember, anticholinergics, anti-sludge, you're going to slow down the GI tract, hopefully slowing down the diarrhea, thus giving your body more time. Things to be aware of with diarrhea that I should have mentioned earlier is with potassium is diarrhea can lead to hypokalemia. And I just realized I never talked about how you treat hypo and hyperkalemia. I'm sorry about that, so I'll do that now real quick. So in hypokalemia, what you're going to want to do, which can be caused from diuretics, extreme diarrhea, something like that, is you have to basically give them potassium supplements. You need to give it orally, in the pill form. And if you give it as a pill, it's very important you don't crush it. They are very large pills, but they're easily dissolved in some sort of applesauce or pudding. So someone that has a hard time swallowing large pills, you can give it that way. Otherwise, you can give potassium IV. If you give potassium IV, it's very corrosive to your veins. It can cause phlebitis. So you're going to give it slowly. It's in a peripheral IV. You're going to give 10 milliequivalents an hour, which is a very slow titratable infusion. Or if you have a central line, then you can give it 20 milliequivalents an hour. Again, you don't want to give it too fast because too much potassium at once will cause your heart to go into hyperkalemia, thus you go into cardiac arrest and die. Lethal injections in jails are generally high doses of injected potassium. So if you really don't like your patient, you could probably just squeeze that bag in there and you end up killing them. But then you go to jail. So you don't really want to do that. But food for thought. Otherwise, there's someone who is hyperkalemia. Generally, for your class and purposes, there's only one treatment, that is K-exolate. K-exolate will then causes you to basically have diarrhea, so you're going to lose the potassium ions in your stool. Other things to be aware of with hyperkalemia, what you can do is, I'm just going to put out there in case you see it in ATI or in NCLEX World, you can give insulin. IV insulin causes not only your blood sugar, glucose to go into your cells, but also causes potassium to go into your cells. So you can give someone like 6-8 units of IV insulin, will help correct their potassium. You also want to give them an amp of D50 because you don't want them to go hypoglycemic. So you're going to give them the insulin to correct the potassium. That's when you give them the dextrose to counteract the effects of the blood sugar from the insulin. You can also give, along with that, you will probably give calcium gluconate and sodium bicarb. Those kind of help affect the cells to, again, reuptake the potassium. That's a very higher level nursing care. I'm just kind of giving it to you now, so if you ever see an NCLEX question or an ATI, sodium bicarb, calcium gluconate help lower your blood pressure, your potassium. Also insulin, but then also give your dextrose with your insulin. Sorry for missing that earlier. Lastly, we have anti-hyperlipidemics. This is very easy. I'll go over it very quickly. The first ones are your statins, your HMG coenzyme A reductase inhibitors, i.e. statins. Basically, they're called statins because they all end in statin. What these do is these will decrease the cholesterol synthesis in your liver. Your liver makes your cholesterol. Your liver makes cholesterol at night. So when it gives you medications at night. What these will hopefully do is help lower your LDL, which is your bad cholesterol, also decrease your VLDL, and then increase your HDL. Your HDL is good, your LDL is bad. This will hopefully also decrease the risk of plaque in your blood vessels, also decrease the risk of embolisms. So the problem you need to be aware of is it can be very toxic on your liver. So anything that's toxic to your liver, you don't want to have any sort of alcohol abuse. So you're going to want to tell your patients not to drink. We live in Wisconsin, so odds are they drink excessively. And so you're just going to want to teach them that when you're taking a statin, it's affecting your liver. Alcohol affects your liver too. So random nursing food knowledge here for you. When someone takes in alcohol, the liver will synthesize the alcohol before anything else in your body. So if you have something that's nephrotoxic or hepatotoxic, it's going to sit in your bloodstream, affecting your kidneys and your liver, while your body gets rid of the alcohol first. So the alcohol affecting your liver, affecting your synthesis of the medications, but it's also causing those other medications to stick around before the alcohol gets out. Just general knowledge. Another thing to be aware of is myopathy or rhabdomyolysis. Myopathy is the breakdown of muscle cells. The breakdown of muscle cells causes an increase of myoglobin into the bloodstream. Myoglobin is basically muscle cell tissue. Myoglobin is very toxic to your kidneys. So if someone has rhabdomyolysis or myopathy, they're going to have muscle pain. It's basically the muscles getting broken down. And so you have decreased muscles, but that's going to lead to kidney failure from that myoglobin being released. You also need to be aware of any sort of patients are pregnant or lactating, because the statins will cross the placental barrier, the placental blood barrier, and then also cross into the breast milk into the infant. So it'll either go into the fetus and stop the fetus from making its own cholesterol and affect its own liver, thus having the fetus go into liver failure before it's even born. And then in the infant in the breast milk, it's going to also again affect their own immature livers, causing hepatotoxicity and then death. So it's very important to get into that through proper education. You're also going to monitor liver function, your LFTs, your liver function test, your liver enzymes to make sure that things aren't elevated and the liver is working properly. The next one is fibrates. These you can kind of identify because they have like fib in the middle. Generally speaking, these work the exact same way as your statins. They're going to help you decrease your LDL, your VLDL, increase your HDL. Give at night, because when your liver is making the cholesterol, same problems of rhabdomyolysis, same problems with the myoglobin, kidney failure from that. But then also you're going to see either cholelithiasis or cholecystitis, which basically is gallstones and gallbladder inflammation and pain. Now, if that happens with your gallbladder, it's very easy to remove your gallbladder, thus taking care of the problem. But you're just going to be aware of it. Last one is cholesterol absorption inhibitors. This one is Zayeta. Basically what this does, this is someone who, through the grace of God, decided that, hey, I know I have high cholesterol. It's probably because I'm in Wisconsin, I have a horrible diet of beer and cheese, things that are high in cholesterol and bad for me, so I'm going to change my diet. So I'm going to decrease my cholesterol intake. So cholesterol absorption inhibitors, basically what they do is they cause your bile acid to bind to the cholesterol, and it kind of gets bind, so it doesn't get absorbed, and it goes out in your GI tract. So this only works if they decrease their cholesterol intake. If they keep eating a large amount of cholesterol, the little bit of cholesterol that isn't getting absorbed is not going to be very effective. So it has to be with diet, exercise, some sort of changes. Odds are they'll probably just be in a statin or a fib or maybe even both. The problem is with these is if they're not actually following through, it's not going to have any effect. And so, actually, I think I misspoke here. So cholesterol absorption inhibitors just affect the absorption of the cholesterol. The bile acid sequestrants, I should have looked at my notes before I start talking. These are the ones that actually bind the cholesterol to the bile acids and it's secreted. The cholesterol absorption inhibitors basically stop cholesterol from being absorbed. Your bile acid sequestrants or your I'm very bad at pronouncing words today. In this class, so it's kind of funny, but they all end in chol. So these are the ones that the bile acid thus binds to the cholesterol and gets excreted through your GI tract. So the problem with these is, one, if someone's on it, they have a very high cholesterol-filled diet, they're basically going to cause them to excrete a large amount of cholesterol through the GI tract, which kind of basically means they're going to defecate, crap out just large amounts of fat. It's going to be disgusting. It's going to be oily, greasy, so it can lead to some sort of anal leakage, some sort of GI complications. It's going to end up having horrible diarrhea. And so you want to teach them not to have those high cholesterol meals because they're going to poop their pants. The other thing to be aware of in a bile acid sequestrant is you're taking those bile acids in the stomach and they're going to bind to the cholesterol into the GI tract, and so the bile acid is not going to be there to absorb any other medication, help break down other medications to metabolize them so they can get absorbed. So you need to either A, give other medications an hour before you give these, or you have to wait 4 to 6 hours after you've given it before you can give another medication. Odds are, if you're giving it at night when you are, what's going to be when you give it with meals? Sorry, I misspoke. So you're going to give it with in the morning. And so you want to give their morning meds first, wait an hour, and then give this. The other thing to be aware of is it's going to affect your absorption of your fat-soluble vitamins in your meals, which is your vitamin A, D, E, and K. So because they're fat-soluble, you need that cholesterol kind of in the diet, in the GI tract, to absorb those vitamins. So you're going to try and get some supplements for those vitamins throughout the day because you're kind of going to decrease the effect. Okay, that's everything I have for you guys. I did go through it very quickly. Hopefully it makes sense. I didn't screw up too much. I had a little bit busy weekend, so I didn't have a good time to go over it. But if you have any questions, let me know. I know your tests start Wednesday, Thursday, Friday. I'll try and get back to you as soon as I can. And if I missed anything, let me know. I'll go over it. And we'll go from there. Thank you.